Hello, you all, and welcome back to Professor Truelove's Concepts for Nurses series. And in this episode, we will be continuing our discussion about strokes, talking in this case about stroke deficits and interventions. As usual, we will be using as our sources Iggy's Medical Surgical Nursing 9th edition, as well as Soul's Introduction to Critical Care Nursing 7th edition. In a previous episode, we discussed strokes and what they are and how they're classified. In this episode, we're going to be looking at the manifestations of that stroke, and we will discuss some of the cognitive deficits that can occur because of the stroke. These include short and long-term memory loss, a decreased attention span, an impaired ability to concentrate, and even altered judgment. The nurse should remember to orient frequently, to use uncomplicated language, to match visual with verbal cues, and to repeat instructions as necessary. Further, cognitive deficits can occur. These are known as motor sensory deficits. They include verbal deficits, that is a type of communication problem, including aphasia, the total loss of comprehension and use of language. It is the loss of words, however, not the loss of the intelligence. Expressive aphasia is difficulty with speaking and writing, the poor naming of objects. It takes great effort and can lead to frustration. Your treatment is to encourage the patient to repeat themselves, to attempt other types, that is, other ways to communicate, to provide for speech therapy, and even ask simple yes or no questions. Receptive aphasia means that the sound of speech and the meaning of speech is understood, but the patient can't comprehend verbal or written speech. With global aphasia, there is some combination of both. Dysarthria is the difficulty in articulating speech, forming words. That is, the mechanics of speech, not the understanding of speech, are problematic. Some have a combination of aphasia and dysarthria. The treatment is to allow the patient time to form words, to provide for other means of communication, and to support the patient. They also suffer from motor sensory deficits, including hemiparesis, hemiplegia, and dysphagia. Hemiparesis is a weakness of the face, arm, and leg, usually on the opposite side of the brain injury. This can also include paralysis of the face. Hemiplegia is paralysis on one side of the body, and it occurs in various degrees. Nursing management is to provide a range of motion to the effective side, exercise to the good side, splints for good alignment, proper positioning, and to place objects within reach. Dysphagia is difficulty swallowing. Again, it is a type of motor difficulty. The treatment is to test the gag reflex, monitor while consuming meals, provide for a swallow evaluation, try to place foods on the unaffected side of the mouth, and allow sufficient time to finish eating. Patients may also suffer from types of visual deficits, including hemianopsia and homonymous hemianopsia. These are types of sensory loss of the visual field. In homonymous hemianopsia, the blindness occurs in the same side of the visual field of both eyes. Therefore, there is difficulty with spatial orientation, like judging distances. The patient may be unaware of a person or objects on the side of the loss, and they may neglect one side of their own body. Their treatment is to place objects within the visual field, approach from the intact visual field, instruct the patient to turn the head from side to side for check for hazards. Other types of visual deficits include the loss of peripheral vision, that is, the patient is unaware of objects to the side of their visual field. To treat this, you can place objects in the center of the visual field. Another problem is diplopia, or double vision. An important part of any total nervous system assessment includes assessment of the cranial nerves and cranial nerve function. The nurse should recall that the ability to chew is mainly governed by cranial nerve 5, the ability to swallow, cranial nerves 9 and 10. Facial paralysis or paresis can be traced back to cranial nerve 7. The gag reflex is affected by cranial nerve 9, and impaired tongue movement by cranial nerve 12. All of these, remember, can lead to dysphagia, the dangerous condition of having difficulty chewing or swallowing foods or liquids. Other problems associated with stroke include emotional deficits, including the loss of self-control or emotional lability. Emotional lability are disproportionate displays of emotion to what is occurring, and they are unsteady and subject to quick change. This emotionality tends to suggest the presence of a number of conditions that may involve the brain. The symptoms of emotional lability might vary among individuals and the frequency of occurrence. Fits of laughter or crying jags are two examples. Some people do evidence this with very explosive tempers, and there can be instances where people will experience all three emotionally excessive experiences at various times. When these expressions occur, it is often daunting for the people undergoing them because many people know that their emotional response is in excess to the circumstances. It can even get embarrassing for some individuals or be a condition that makes them withdraw from society. Strokes may also cause impaired physical mobility and a self-care deficit. Interventions for these include range of motion exercises for the involved extremities, a change of patient's position done frequently, prevention of deep vein thrombosis, and therapy is focused on the patient's performance of activities of daily living. The nurse should be aware of interventions for disturbed sensory perception, because it turns out that the right hemisphere damage typically causes difficulty in the performance of visual perceptual or spatial perceptual tasks. This means the patient will need assistance with ADLs in ambulation. Left hemispheric damage generally causes memory deficits and changes in the ability to carry out simple tasks. The intervention there is to provide reinforcement. Unilateral neglect is a syndrome most commonly seen with right cerebral stroke. In this case, the patient is unaware of all or portions of the affected side of their body. You should teach the patient to observe safety measures, touch and use both sides of their body, use the scanning technique of turning the head from side to side in order to expand the visual field. Impaired verbal communication are language or speech problems which are usually the result of damage to the dominant hemisphere. Expressive aphasia is the result of damage in Broca's area of the frontal lobe, whereas receptive, that is, Wernicke's or secondary aphasia, is due to injury in the temporoparietal area. Interventions for impaired swallowing include assessment of the patient's ability to swallow, patient positioning to facilitate the process of swallowing before feeding, an appropriate diet for the patient, including semi-soft foods and fluids, and aspiration precautions. An altered level of consciousness may cause a urinary and bowel incontinence, or impaired innervation, or an inability to communicate the need to toilet. The nurse should therefore develop a bladder and bowel training program to cope with these issues. Other types of intervention include cooling as a way to preserve neuro cells. This may include, by the way, neuroprotective drugs. That is a way to calm down the metabolism of the neurons to preserve them. You may restore blood flow to the affected part of the brain using thrombolytic therapy. The patient may be eligible for carotid artery angioplasty with stenting, also known as an endarterectomy. In some cases, bypass will be performed on the brain, known as an extracranial intracranial bypass, and if the patient is suffering from increased intracranial pressure, a craniotomy may be indicated. Medication therapy for the patient suffering from stroke may include the pre-mentioned thrombolytic therapy, but may also include anticoagulants to prevent further clotting, lorazepam and anti-epileptic drugs to reduce, that is, protect the brain and the brain cells, calcium channel blockers for vasospasm, stool softeners to prevent straining, analgesics for pain to reduce sympathetic nervous system response, and anti-anxiety drugs to perform the same job. We did discuss thrombolytic therapy in the TIA and stroke episode, but a quick review will show us that thrombolytic therapy is done IV, that is systemic, and therefore causes systemic problems. The only approved agent is RTPA. Recall that there are tools to determine eligibility criteria. These include but are not limited to things such as time last seen normal and the NIHSS. Remember, your priority of care continues to be ABCs. Complications of thrombolytic therapy designated for stroke include hydrocephalus, vasospasms, bleeding, rebleeding, or rupture of an existing AVM or aneurysm. Because of this, the nurse should monitor for signs and symptoms consistent with increasing intracranial pressures, provide for safety, particularly in those patients suffering from neglect, unilateral neglect, visual disturbances, or others, provide for emotional support for the stress of being diagnosed with a stroke, and provide for education, including but not limited to community resources. That does conclude this episode of the Neurological series. However, the series continues, with the next episode being dedicated to traumatic brain injury. We'll see you then.